All right, well, it is 101, and I am going to go ahead and start. First of all, as you're filtering in, thank you for joining us today. Please do put your name, your organization, and your location in the chat for us. That helps everyone in this group. This is a large group of registered attendants today, about 200. It's going to be a great and fast-paced hour together, so please put your name, organization, location in that chat. I want to give you a quick sense of who's going to be joining us all today. We have everybody. This is philanthropy, this is academia, this is think tanks and do tanks. This is from the smallest to the largest social service organizations in our country. We have from the smallest entrepreneurial nimble to the largest health insurance carriers here. We have health systems and hospitals and community-based organizations, a lot of community advocates. Thank you for joining today. I know how pressed your time is. We have faith-based organizations. We have our state partners from all across the states, from the coldest ones to those experiencing heat waves. Everybody's on today. Thank you for joining us. We have our federal partners. Thank you. I know it's hard to make time for this. We're going to make great use of this 1 hour, and we have some fantastic ideas and great people to present them to you. So thank you for joining us. Welcome to Health Starts Here, strengthening the policy environment around social factors of health. That is the name of our blueprint, which is the grouping of our consensus solutions. We're not going to talk about them all today, but we are going to link them all today. So please do get familiar with that chat feature. You're going to see a lot of activity in that chat. Before I even introduce myself, I really want to introduce the organizations that stepped up early and partnered with us on funding and made it possible for Convergence to host the Convergence Collaborative on Social Factors of Health. Thank you, Common Spirit, Episcopal Health Foundation, and Kaiser Permanente. You are making this work possible for us, and everybody on this call, we're going to enjoy the fruits of that partnership today and the ideas that are going to make it easier to invest in our communities and individual health by addressing social factors of health. So thank you so much. Our work wouldn't be possible without you. Without philanthropic support generally, this kind of work can't happen. So I know that as you see everybody build out and these 200 some odd registered attendees for today, we have a lot of philanthropic supporters that are joining us today. Thank you for making this work possible. Our honest brokering and neutral convenings through Convergence couldn't happen without you. So thank you for doing this. We are working now to implement these solutions. We've just begun the implementation stage. This is actually part of our outreach beginning this. I wanted to also thank United Health for stepping in as an early contributor to our implementation stage. I know others will join, so thank you so much for all of everybody's support for this work. Now to quickly introduce us. I'm Karen Hederman. I'm co-director with the amazing Dr. Stuart Butler of the Convergence Collaborative on Social Factors of Health. I'm an actively licensed lawyer, a former litigator, former federal lobbyist. I'm also a federal science and tech geek at heart. So that's what I'm bringing to this work. I've had the pleasure of directing 5 separate Convergence policy projects as an independent consultant. Beginning in 2013, Stuart Butler pulled me into the Convergence Long-Term Care Financing Collaborative with Rob Fursh. Thank you, Rob. Rob's going to be joining if he hasn't already. Stuart Butler, I'm going to talk quickly. I can never pass up the opportunity to work with Stuart. And as much as I am a lawyer and a science and tech person at heart, Stuart is a historian. He's a policy change maker. He's a leading mind for Convergence since Rob first brainstormed this wonderful little organization into existence in 2009. This collaborative and many others is Stuart's brainchild. Thank you, Stuart. It's a wonderful example of how great hearts and minds can make a difference, right? So we're here today to share our excitement about the work with you and to describe the consensus solutions that were recently released in our Blueprint for Action, Health Starts Here. When these solutions are implemented, they will enable cross-sector partnerships and policy conditions that will improve people's health, individual health, and strengthen our communities. The fun and impact of our work arises from the opportunities created by our consensus building in this Convergence project. And for that reason, and because she's great, I'd like to now introduce Mariah Levison, the CEO of Convergence Center for Policy Resolution, to give us a little bit of context about who Convergence is and why Convergence organized this project. Over to you, Mariah.
Thanks so much, Karen. And thank you everyone for being here today. We're so excited to get to know each of you more and to share the group's work. So as Karen said, I'm Mariah Levison. I'm the CEO and president of Convergence Center for Policy Resolution. And I am myself a consensus builder by background, which means my whole career, my whole job has been bringing people together across divides to help them find common ground and pathways forward for working together. We do that work on significant issues at the national, state, and local levels. Convergence started in 2009 to bring together divergent leaders to build trust, identify solutions, and catalyze unlikely alliances for action that can unstick seemingly intractable problems and create conditions for ongoing coordination. Convergence is especially focused on a couple of issue areas: economic opportunity, democracy and civic engagement, and importantly for today, and as Karen talked about the many projects she's worked on, health and well-being. In addition, through Convergence's Learning Lab, we also offer training and tailored engagements in collaborative problem solving to help businesses, higher education, government, community leaders navigate the divisions that increasingly, unfortunately, many of us are facing today. If you're new to Convergence, I urge you to learn more about us and welcome you to find a place in our community of people dedicated to bridging divides to approach our country's challenges. My colleagues are sharing some more information about ways that you can engage with us in the chat. And so with that little bit of background about Convergence, I'd like to again thank all of you for being here, and especially to thank Stuart, Convergence's esteemed board member and advisor, from whom you will hear shortly, for having the vision to address challenges around social factors of health with the Convergence approach, Karen for her formidable leadership of the project, and other Convergence staff members who supported the project and this event, including Marcy Cabello, Olivia Daigle, Duzi Casada, Alex Frazier, and others. Thank you.
Thank you, Mariah. And welcome, Stuart. Stuart Butler, I'm going to give you his formal titles. Stuart is Scholar in Residence with the Economic Studies Program at Brookings Institution, a member of the Convergence Board of Directors, and my co-director on the Convergence Collaborative on Social Factors of Health. Over to you, Stuart.
Stuart, you're on mute.
I know. I'm going to hire you, Karen, as my publicist to deal with my daughters and explain to them why I'm smarter than they think. But it's been great working with all of you, actually, in this project. And I just want to really just sort of put it in context, say a little bit about the nature of the project itself, and then give you really a sampling of the recommendations and why those recommendations emerged from this process. If you go back about 10 years, I've been working in this area for a very long time, but if you go back about 10 years, you know, I and others of you would have to spend time explaining to most audiences why things like housing and social services and nutrition so on actually was really important for health. And if you get those other things right, it might actually improve the quality of health services and reduce the need for them. Then I'd say about 5 years ago, we really began to see health organizations, the government at different levels, really beginning to get serious about this. Say, okay, well, let's actually start to focus on how to do this. And I would say they increasingly found, and this is what we heard in some of our initial conversations with people, that they found that the regulatory and statutory system that they're under, both at the federal and the state level, was really not designed to promote this approach to improving health and coordination in that way. And that there were many obstacles, uncertainties about what people could and couldn't do, what programs permitted, and so on. And about that time, I think the federal government also began to take serious steps in the right direction, began to look at these issues. And that led more recently to things like the federal government issuing what they called a playbook for state and local organizations to say, this is what you can actually do under the law. It was a start. It wasn't comprehensive, but it was a start. And then using waivers in the Medicaid program, the so-called 1115 waivers, to give states more opportunities. So you really have had in the last 5 years, I would say, a lot of this kind of activity, beginning to kind of look seriously at how to connect these different services in order to improve general health. And increasingly, because of to the extent there is misalignment, we just found in our initial sort of probing on this issue that organizations really, and individuals and community groups really want to have a policy system that's aligned to partnerships across sectors in housing and nutrition and social services, education, and so on, to work better. So they wanted the best possible policy framework to encourage these local activities to move forward. So that's why at Convergence, what we did was to bring together initially for some brainstorming sessions, just to hear what people's opinions were, to really start to begin to think through, well, what would that policy framework actually look like that could be agreed by everybody and would work for everybody? And so we assembled just over 40 organizations and people and individuals, including, by the way, a number of observers from federal agencies and so on, just really to listen to this. And if you look at the list, you'll see it's a very wide-ranging group of people and organizations, from major health plans to major social service organizations and housing organizations, nutrition groups, and so on. So and also, in addition, organizations that currently in their own sectors were working towards trying to develop these policy frameworks. So we brought them all together, not literally, but figuratively, into the same room to begin to learn from each other as well. And we used the process that Mariah has mentioned to you in terms, because this, as we discovered when we explained this process to the people we assembled, they felt the timing was right for this approach to trying to devise and agree on an effective system of laws and regulations. They agreed it was right because, first of all, it was a slow process. It took well over 6 or 8 months. And that allowed trust to be built. It allowed everybody to be heard. There was a lot of listening. So it allowed people from different sectors to really begin to appreciate both the values, the vision, the objectives of other sectors. That was really important to get people to understand each other. And they began, therefore, to understand why certain policy goals, say in the health sector, really were important for those in the housing sector or nutrition that were trying to address these social factors. And also by building up that trust, it allowed organizations to be more open to be making some modifications, some slight changes in what they had been previously supporting in order to build up broader support for a common agenda. And Convergence, our role and my role and Karen's role was not to try to lead them to some foregone position, but to be an honest broker and a facilitator, to ask probing questions, to just really encourage that conversation, to recognize when there were tensions and try to dig into what was behind all those. So over a total of nearly 9 months, we focused around 4 broad policy areas. These sort of began to emerge as we went along, and I'll just list them here. The first was actually and they're all kind of fairly obvious when you think about it, but then the devil was in the details of figuring out the specific objectives. But getting programs and departments at all levels of government and in the private sector as well, to work together much more seamlessly to support common initiatives. And I'll say a little bit about that when we talk about the initiatives themselves. Secondly, that in order to get the kinds of collaborations that are needed in this area and an understanding, you have to have a workforce that had members of that workforce at all levels who had the skills, the authority, and the support to coordinate services. Coordination was emphasized all the way down the system, from the very federal level to within individual communities, and to make sure we had people that had the authority and the skills to do that kind of coordination work, which is often lacking. And then thirdly, figuring out, of course, this is Washington, who pays and how funds can be used flexibly. Again, I'll talk a little bit more about this, but how we can use existing money more creatively, and to the extent that we need more, what is it? And then last but by no means least, data just kept coming up of organizations saying, we need to be able to share data more effectively. We can't. There are all kinds of restrictions. We've got systems that don't operate with each other. Everybody wants to keep their data together and not share it, and so forth. That finding ways to do that would enable much better referrals to be made across sectors for people who need social services rather than only healthcare. It would allow much more experimentation. So if we have good data, we can know what's working and not working, and use that to refine. So that was kind of the groupings that began to emerge. And then what I thought I would do, right, obviously you need to look at the whole report to understand and to see a lot of the rationale and a lot of the specifics. But I thought I'd take a couple of examples just from each of these areas to give you a sense of why that recommendation sort of came to the fore, and sort of what it was intended, what problem it was intended to address. So let's look first at that whole area of improving system integration. I've just taken two. One of the things we heard over and over again was that uncertainty, not knowing how you could use existing federal funds and state funds, and whether you could mix them together, and whether you could use some health-related money for improving air conditioning in a housing project to deal with respiratory issues. They didn't know. So even though this is in a sense, a very simple recommendation to say, give greater clarity and consistent guidance, that was emphasized over and over again. We just heard story after story of organizations and individuals calling different agencies involved when they wanted their programs to be used together, and getting totally different answers about what was possible and not possible. And that discouraged a lot of activity. So getting clarity in a consistent way and doing a much better job was a very important recommendation that was emphasized. Then the second one I just want to pick up on here is this notion of hubs. In addition to talking about collaboration at the government level and among programs, there was absolutely a consensus that we had to have in communities themselves what everybody referred to as hubs, organizations, either existing organizations or newly created ones, that in the community itself did the kind of very detailed bringing together of services and dealing with those issues. Institutions like that had to be in different communities, and therefore the collaborative members argued very strongly for giving these organizations as much flexibility as possible, technical support, building up their data systems, and giving them actually higher rates of payment if they were successful at bringing different sectors together. So each of these, as you'll see, recognized a problem and suggested, in most cases, a fairly simple answer, or at least an answer that doesn't require new federal statutes or anything like that to move it forward. We have the same with regard to building the workforce. That, as many people said, coordination is often nobody's job. Nobody is really a coordinator and have the skills and the authority to get different institutions and different programs to work together. So there was complete agreement that it was very important to both recognize and create a well-paid, well-trained coordinators who had authority to move forward. And hence the licensing issue, training issue, and so on was a very important sector. And just as a bottom line, generally, that CMS, running Medicare and Medicaid, and other institutions have got to pay for coordination in a serious way. Often that can come through quality measures, improving the quality of services, but it's got to be built in a way that it isn't done sufficiently today. So let's move quickly on to financing. A lot of the discussion there was how can we use existing money more efficiently? America tends to spend much more on health compared with other services than is true in most other industrial countries, certainly. So using money differently, and that was hence the interest on 1115 waivers. These are the Medicaid waivers that permit Medicaid money to be used in somewhat different ways if the state proposes it. But to use this money more effectively and to look at ways to allow much more combinations of money. And then in addition, and kind of related to that, to really focus at all the levels on budget process. It sounds like a very arcane issue, and it is in a way, but the way budgets are designed and the way that departments have budgets and can use money often creates what we call wrong pocket problems, or wrong pocket disincentives. That it may make a lot of sense, for example, for housing, to a housing authority to improve the safety and quality of housing, and say for the elderly, but it's not that housing authority that reaps the benefit of that. It's the Medicare program, typically, a federal program. So you want organizations that don't necessarily get the direct financial benefit to work together, and hence looking at budget processes to do that was seen as absolutely central. And then looking finally at the data area, as I said, data just came through over and over again as a critical issue. A lot of that was uncertainty about sharing data, privacy concerns, other concerns, particularly looking at things like sharing education data or housing data with hospital systems and vice versa. So giving consistent advice and sort of safe harbor advice on using data to avoid breaking the rules on privacy and so on was a really important recommendation. And then sort of finally, last but not least, that building up data systems within hubs, local communities, between government departments, looking at interoperability was a very important recommendation that the group came to. So this is really a sample of, as I said, of the recommendations, and to give you a sense of really why they came to the fore, what the issue was that they were addressing, and then sort of what steps we got complete broad agreement on throughout all the groups. And we feel, and the organizations felt, that by agreeing in this way and working together, this could be a very powerful statement and encouragement for agencies and for the Congress and for state houses to do the kinds of things we know will lead us to where we want to be on social factors. So let me hand back to Karen, because we have some individuals who went through this process and can tell you even more from their personal and organizational point of view about it.
Thank you, Stuart. I now have the pleasure of introducing three members of our about 36 members of the Convergence Collaborative on Social Factors of Health, so you can hear directly from them about the significance of this work, the importance of it to them, to their organizations, and to our communities. While we are doing this panel and ideas and questions come up in your mind, please put your questions in the chat. Use that chat. What we're going to be doing is I'll try to be in the question and answer session. I'm going to try to group them. So don't be shy. Get them in there. That's also, we're not going to be taking questions during the panel, but we will absolutely go to the questions after the panel. So please use that chat. Now for our three amazing panelists. Brian Corbin is the Executive Vice President for Member Services at Catholic Charities USA. Blair Harrison is our Policy Director, Population Health and Social Care at United Healthcare, Community and State. And Sue Pacillo is Vice President, Public Relations and Government Affairs at Lutheran Services in America. So thank you three for joining us. You are all very just incredible hubs of information. And I can tell you in a lot of the conversations that I've been having just over the last week with Stuart, with people for other reasons, people are very excited about hearing from you and hearing from the members of this work to hear why it matters to you, what's important to you. So I'm going to start off with the first question, and we'll go from there. The first question, what I'd like to do is we'll start with Brian. I'm just going to go in the order for this question that I see you on my screen, which is Brian, Blair, and then Sue. Okay. Please share an example of a recommendation that's critical to your organization's objectives, all right, in addressing social factors of health, and why multi-sector agreement and support for that solution would make a difference.
Sure. Well, thank you. I'm Brian Corbin with Catholic Charities USA. So part of it is Catholic Charities as an institution. We're in many communities around the United States, 3,000 sites. We do a lot of the work in the social determinants of health. And one thing that hit me, two things that really hit me. One was what Stuart was talking about, wrong pockets. So I ran a Catholic Charities agency for 27 years in Youngstown, Ohio, in 6 counties in Northeast Ohio. And we kept on finding that somehow, the work that we were doing in social determinants and then looking at the larger health budget, there was always it's a mismatch. And right now at the national level, we have a pilot program called Healthy Housing, which is working in 5 cities with Catholic Charities providing housing and working with a health institution, trying to reduce ER, high flyers, as some people call them, and trying to, that if we can house people with our case managers and our mental health providers, can we reduce ER visitations? And we know, I used to be the treasurer of a healthcare system, it's very expensive to do primary care in an ER. And so what we've been finding in these 5 cities that are being tested right now is that we have reduced ER visitations of the clients, of the people that we've housed and taken care of. However, in a wrong pocket scenario, no one's paying for those case managers, or we're paying for those case managers and other people are benefiting from it. We're happy to do that, but is that the way to really do best healthcare for a community? So that was one thing that hit me very clearly. And the other thing was the issue of hubs. I served as the local chair of the Continuum of Care for HUD. I also served as the local chair for the Emergency Food and Shelter Board. Again, we have federalism at work in the United States, in HUD and in FEMA, where local communities kind of look at their resources and divvy the task. So this was a great and exciting thing for me to think how we could maybe do it in the social determinants of health. Thanks, Karen.
Thank you, Brian. That's fantastic. Miss Blair, I'd love to hear your thoughts.
Hi, everyone. So I think maybe helpful to start. Prior to working in Medicaid policy and advocacy with United Healthcare, I worked at a state health department in Minnesota and also in local public health. I've also worked in university, hospital, and healthcare systems, at the VA hospital, at a children's hospital, in startup healthcare, and at a community-based nonprofit health organization. So happy to bring a diverse set of experiences from the healthcare side to the conversation into the convergence work, but also want to just note that I think this work is so important because in any of those places along the health system continuum, these recommendations matter and have incredible meaning. As Stuart said at the top of the conversation, I think today, regardless of where we sit, we know that social factors drive health outcomes. And in fact, we know that what happens in a clinic setting actually contributes very little to a person's health and well-being compared to the impact of where we live, where we work, where we play, structural system level factors that influence health. So to that end, in the last 2 years, we've seen some really significant policy changes at the federal level that are encouraging states to really leverage new and expanded flexibilities in their Medicaid programs to address the health-related social needs of the communities that they serve in their state. I think important to note, too, that those policy changes are lockstep with bigger efforts around reducing and eliminating health disparities and advancing health equity. So there's also this really broad understanding that if we only focus our health conversation and our health work around what's happening in an exam room, we aren't going to see the big changes in outcomes that we're looking for and that we need to see. So specific to the blueprint, the two Medicaid pathways that we talked about that I work on every day and that I think are really important to this conversation as a whole are looking at in lieu of services, which are, I think, of a smaller tests of change, but then 1115 waivers, which are really aimed at bigger system transformation. And those pathways exist today. Those are ways for us to test how partnerships happen in this sort of multi-sector, cross-sector way, what finance models are going to work, what type of clinical changes and programmatic changes are necessary to advance our SDOH work. But we've also in the blueprint laid out some specific recommendations to just even maximize the opportunity and possibilities that come with these pathways. And we specifically talk about evaluation. I think we've been really lucky that states like California and North Carolina, who are well underway in their health-related social need waiver work, have been really forthcoming and transparent and leading and sharing their early lessons learned. But there's a lot happening right now, both in the waiver space, but across other big initiatives and efforts as well. So we really called on CMS through the blueprint to build out a structure for sharing those lessons learned so that we can really take everything in and sort of a rapid quality improvement cycle way of being able to pivot to the approaches that we know are working and having the biggest impact for communities. So that was one that we were really excited about. I think another thing that we talked about in the blueprint that's really relevant around evaluation is when we think about our SDOH work and what's happening today, we can, of course, evaluate and assess through like a really narrow corridor. We can look at, like, if we do A, what's the impact on B? If I provide a medically tailored meal, what's the impact on utilization when we prevent disease exacerbation? But we have this incredible opportunity with waivers and with the infrastructure dollars that come with 1115 waivers to really think more broadly about evaluation. So through the blueprint, we also call on states to really dedicate and be intentional and thoughtful around the investment of data and dollars and resources to build out cross-sector evaluation plans and frameworks that will allow us to really start to get at that more collective social return on investment to tell the whole story of the work that we're doing. When we think about, I know part of the question, Karen, is just how does the multi-sector support make a difference in the work? I think when we are talking about anything in the blueprint, it's hard to even talk about it as a difference that's made because it's just not possible without multi-sector coordination. There's not going to be a single institution or person or organization or discipline that solves any of these seemingly intractable population level challenges that we're up against and that we're driving towards solving with the blueprint and the policy framework of the blueprint. So I think one is just the difference is that it's what makes it possible. And I think the other important consideration is that when we aren't coordinated in this work, when we are operating at the intersection of social care and medicine and the justice system and school-based programs and all of the systems, if we aren't coordinated in that, we actually cause harm. So there's an incredible amount of unnecessary suffering that happens every day when people are disconnected from or across a system, when they're not seen by systems. And it's really important for us, and an effort and an aim of the blueprint was also to break down those silos. So we often design our programs and think about our approaches kind of from inside our organization looking out. And this is an opportunity for us to really be more human and person-centered in our design. And so to really, again, just appreciate and fully acknowledge that who I serve in a Medicaid health plan and who I would have served at a local public health agency, and again, school-based programs and hospitals and social service organizations are often the same individuals and the same families. But we, through that siloed nature of the work, make it impossible to manage just how families navigate across. So I think a goal of the multi-sector approach for me is really that we get away from ever having to say we're trying to create a system that's easier to navigate, but really it's the multi-sector approach and multi-sector collaboration that leads us to building a system that's actually designed by the people who will use it and that benefits those individuals and families.
That's wonderful. Thank you so much. I would love to have Blair answer, I'm sorry, Sue Polis answer this question as well. And Sue, getting back to what Blair just was talking about, the importance of the multi-sector approach, the importance of seeing whole communities and seeing people in the context of the other the services that they're relying on and that they need. Could you talk a little bit in your response? So the question is, please share an example of a recommendation that's critical to your organization's objectives in addressing social factors of health and why multi-sector support for that solution will make a difference. I hope, because you are a guru in so many of these spaces, that you also will give us a lens with a focus on the workforce related to community hubs and distinct from the hub concept as well.
Yeah, thank you, Karen. It's really wonderful to be with you all today on behalf of Lutheran Services in America, our faith-based network of 300 health and human service organizations in 46 states across this country. And it's just this effort with you and Stuart has been so capably led, along with Blair and Brian and others, as you said, right, that contributed so much value to this process. And so, yes, I'm happy to talk a little bit more about social determinants of health workforce. And I think we all recognize, right, it's a really daunting time overall related to healthcare workforce, right? We have a lot of trends coming together with the aging of the baby boomers, escalated health needs and services through and after COVID, coupled with exits from the workforce due to demand and burnout, and stiff competition, right, for trained providers. And so this opportunity to think with a multi-sector group of practitioners and stakeholders from different sectors, came at such a critical time, especially as we think about what's going to be needed to deliver on social determinants of health and through workforce. We, as Stuart and Brian and Blair said, right, the importance of meeting people's social determinants of health needs, right, is essential because stabilizing individuals, right, and preventing greater health-related challenges is essential, right, to improve outcomes and lower costs and improve care, which is what we're all after in an equitable fashion, right? And so it struck me in my previous job at National League of Cities and supporting city leaders across policy and systems, and now the social service provider view, right? I think this has been said, right? No one's job is really to advance a social determinants of health approach, right? And so we talk about the importance of setting a table, and at the local level, that's where we meet people where they are, right? And so case management and care coordination, right, as I've come to know Lutheran Services, these are things our organizations are all fundraising to do independently, right? And so organization by organization, depending on their service lines and the populations they're serving. And so it just is so essential to really start building some muscle in a social determinants of health workforce role to really ensure that broader coordination, right, across those systems that Blair just really nailed, right? She spoke to that so effectively. And so 2 recommendations in particular, right, where we talk about effective coordination requires people with skills who have the necessary authority to coordinate services at different level, along with the role of CMS in building coordination costs into payments, including through Medicaid and Medicare. That was so valuable to come together as a multi-sector group and, consider these questions and now advocate, right, for how we support and incentivize this alignment around coordination. Certainly, as we think about a social determinants of health workforce role, yes, authority and buy-in, right, from key stakeholders with a broader view. And that's what's so, I think, critical and unique about this effort, right? We've seen recent efforts by like the Association of Community Living, their efforts to support a community care hub approach. Brian talked to some of the leadership he provided, including with HUD, Continuum of Care. In public health, we often talk about backbone organizations and wellness trusts, right? And so I think what we're trying to say here is there isn't one approach that's going to work everywhere, but let's really agree and acknowledge that that's a role that must be played. Someone must play it who has authority with both the ability to bring together different funding streams, right? We always talk about braiding or connecting these different funding streams, but also with the data, right? That's going to tell us who and how much and right, and ensure that we have a picture of what this all looks like. And so we know what's working, right? The data is so critical to this too.
Sue, thank you. Thank you, all 3 of you, for your answers on this question. Actually, a couple of things jump out that were big themes in our conversations over the past year that I want to encourage. We don't have a ton of time in this 1 hour, so we're not going to deep dive into them, but we can. I would love to refer you to the blueprint for more information about our centering of trusted institutions within the communities, and for the community sort of community priorities around interventions and social factors to be central. That's a really important theme. We built it into the policies. It's important throughout our conversations. And then data, integrated data systems. Learn and love that phrase, integrated data systems. We talk a lot about data in the blueprint, and we have very specific recommendations that will make a difference. And there are also some things that were surprising that came out of the conversations that people, even these masters of the universe in these sectors around social factors, weren't aware of. So please read that. Send your questions if you have questions about data to me. But we're going to move on to the next question. So thank you, Blair. Thank you, Sue. Thank you, Brian. We're going to go, we're going to actually start with Brian again here. This is what do we need to do to implement these solutions, right? We don't want to be a report on the shelf. Nobody wants a report on the shelf. Tell us what your organization and what you are able to do to implement these ideas going forward and what you're doing now.
I guess a couple thoughts, and this is just my thoughts, obviously. I think it has to go both local, state. It has to go state, federal, and local all simultaneously. Because first of all, federal policy gives the federal construct of how federal funds flow. But as someone who worked in Youngstown for 27 years, I had 6 counties, and all 6 counties were different, very different. And so I think it's important that locally, I'm going to challenge our Catholic Charities agencies and their 3,000 local communities to start convening people of the same types of people we brought to the convergence of the national conversation, to have these conversations about how we can not only do some things that we can do anyway, with or without just what's available, but also how can we put some pressure on local government, state government officials, and then our federal representatives to kind of talk about this in a bigger sense when budgets and appropriations get processed here in Washington. So I guess what I'm trying to say is I think what our institution like to do, not only continue to provide the service we provide every single day, from housing to food to counseling to disaster operations to immigration support, but to convene people in local communities to think through this, do what we can do right now with the law that's in place, but then push it up to talk at the federal level. So those are some just ideas that are floating in my head.
Those are great ideas. Blair, do you mind?
I was taking notes. Yeah, so three things stand out to me. I think the first, as far as successful implementation goes, is that this is, again, an incredibly strong and collaborative policy framework. Successful implementation is it requires partnership with community. And we bake that into a lot of the recommendations in the blueprint. Like, we explicitly call out the need for prominent partnership with communities, whether those are community organizations, community leaders and members, those with lived experience in that particular domain or topic area. But I think the partnership and the leadership from communities is probably, in my mind, the most important part of successful implementation across the blueprint. In terms of just sort of tactical approaches from a health plan perspective or a health system perspective, two things that come to mind are, one, co-opetition. Stuart has a paper on this if you want to do a deep dive into co-opetition. But just the idea that for health plans who are typically oriented towards and geared for competing, there are specific areas where collaboration is sort of what we do in this moment, and we look to differentiate and compete later or in other areas. So when I look at the social factor opportunities, we talk about co-opetition a lot, specifically for things like medical respite for people experiencing homelessness, but there are certainly other opportunities in the social care space where I think co-opetition is really important and will be an important strategy. And then the other sort of tactical piece that I would lift up is just over the last year, what we did organizationally was, as we developed the recommendations through our Convergence Collaborative, we were looking to other internal policy and advocacy priorities, documents that we were working on, sort of guidance and frameworks that we had internally, and made sure that those were aligned. So a lot of the things that we talk about in the blueprint also show up in a path forward, which is the United Health Group set of priorities and policy to making a better, stronger healthcare system that will drive towards healthier communities. So I think that's another thing that I would just say really matters for implementation, is to get that traction and momentum, is making sure that the efforts here are aligned with what we're looking to do organizationally as well.
That's fantastic. Thank you. Sue, please.
Yes, I think just to, build on what both Brian and Blair have said, right? At Lutheran Services in America, we really try to center lived voice for how to better align, right, policy and practice. And so ultimately, the people that navigate these complex, often at times unharmonized, right? They're not harmonized to work together. These unharmonized systems fundamentally know where the gaps and barriers are, right? And so we feel like that's essential. And then, right, this role and mechanism to ensure greater effectiveness and working across systems and funding streams with the authority and administrative capacity, right, for financing and data that we started talking about, and then in behavioral health, right, we have an intercept model. We have hubs, we have backbones, we have wellness trusts, right? So how do we learn and ultimately move forward based on lessons learned, right, to ensure we're getting more efficient and effective systems? And I think bringing different systems together can illuminate that and help us build on the knowledge that exists, right?
That's very helpful. I'm seeing great questions going into the chat too. So thank you very much for these answers on these questions. I want to note also that we are putting together products, and actually they'll be going out for everybody who's participating. You will get an email from us with what we call calls to action, and they're divided by federal, state, private actor, community, and local. And those are ideas of ways that you can take the next steps, ways to think about how these policy recommendations apply to you. So hopefully that will be very helpful as a tool, and you will get that in email from us. Because we're out of time for the panel, I want to ask everybody to abbreviate, everyone on my panel, to abbreviate the last question for you into sort of one sentence, if you can think off the top of your head, what about the collaborative process surprised you? And for those of you who've never participated in something like this, can you tell us a little bit more about your experience? I'm going to start with Sue. Sue, you, and then we'll go backwards.
Well,
Sue, Blair,
I,
Brian.
you know, I alluded this a little bit earlier, but I think just the seminal ability of Convergence to bring together such a multi-sector, multifaceted group of folks. I mean, keep the process moving, delve into all these really complex areas, consider all the feedback. You know, these recommendations are so important because they're so well informed, right, by such a broad group of stakeholders. And, you know, Stuart and Karen, right, you built the trust. You made sure people had a space to really share and learn from each other and then pull through, right, on how to make sense of it all. So I feel really great about what I could contribute, but also what I learned and how we move forward together some of these recommendations together.
Awesome, Sue. Thank you. Blair?
I don't think I can say it better than Sue. So everything Sue said, and just what a humbling experience it was I think it was overwhelming for me to realize how much I didn't know, especially with so many cross-sector partners at the table, and really appreciated the skill of the leadership of the group of distilling everything down and being able to keep us focused and moving forward rather than getting overwhelmed at how much there was that we all didn't know as we learned together. So I thought the process was incredibly effective in that way. Thank you.
Thank you. That's also the fun for us too. So thank you for saying that. Brian?
Echoing both Blair and Sue, but one added insight for me was, wow, I walked into a room with people that kind of understood my frustration, even as a social service provider and a member of a board of a huge Catholic healthcare system, and someone who was a public health president of a board of health. And all of a sudden, those three sectors, there was a group of people that actually understood those frustrations, and you could talk about it and wrestle with it and disagree, but ultimately come to places where you can actually move forward. So that was just exciting for me.
That's fantastic. And that's a great bridge. We're going to hop into questions and answers. I've been seeing lots of questions coming in the chat. And please, if you had questions from the panel, go ahead and dump them in the chat. And Marcy's going to be aggregating them for me and putting them over. One question I want to hit off the top of the bat, and I'll do it very quickly, and then we'll move on to others. But I do recommend you read the first couple of pages of the blueprint. People are like, why'd you spend so much time talking about why you use the term social factors of health? There are a lot of different umbrella terms that are used to describe the different elements of a person's life that are not medical interventions, which affect your health or my health or our community's health. Those are often called social determinants of health. And we spend a lot of time talking about in the report why we use social factors of health and why we're using an umbrella term. We use SDOH because everybody knows what we mean, and everybody dislikes that term. Nobody likes the idea of determination, right? And there are a lot of different terms that are used, health-related social needs, and there are a lot of different terms that are used. And the reality is, the more conservative and free market the thinker, the less likely an umbrella term is used at all. And I wanted to make sure in our conversations throughout that everyone brought their best ideas to this table, because from left to right, everybody cares about this space. We all care about strengthening individual health through everything that affects your health that isn't medical intervention. And we care about strengthening our communities in that way. So we wanted to use language that everyone could both understand, right? That's the first thing that you have to do, but also that didn't feel like we were coming into the process on a particular part of the ideological spectrum or with a particular outcome in mind. So that's why we use the term. I would love everyone on this call to realize that when you're thinking about an umbrella term, if you're speaking to somebody that you're trying to win over and persuade to work with you, to partner, it's often best to talk about the specific factors that are of highest priority to the communities you're working in, because that gets everybody. But that's why we use the terms. So I'm going to ask the panelists to weigh in on a couple of questions here. One is, can you give some examples of intergenerational initiatives? And I can think of the community hub process. I can think of a lot of things that are social factors, but in your social service organization efforts, Brian, in the gazillion things that the programs under United Health do, and Sue, you have done so much. Can you think of a great one thing that you can talk about with intergenerational importance?
I can't say like one thing, right? Because so many of them, and this is probably true, Brian, at Catholic Charities, right? That our members work across so many different populations and service lines. It's just fundamental to who they are and how they do the work, right? So it can be senior services, people with disabilities, and children and families, right? So it's almost core to how they function and operationalize their community-based organization and practice. So it would be hard to say one example, but Brian, what would you say?
Yeah, I was struggling with that question too. I know of a couple of our Catholic Charities agencies that are kind of working, Santa Clara County, I think specifically in California, and I think in Baltimore, where communities of housing and senior living are connected to a parish school with kids or daycare centers. So they have some intergenerational work that kind of keeping everyone healthy and in a sense of kind of helping case manage intergenerational communities. So I'm a little bit struggling with the question as you did, Sue, in that very technical aspect, but I think there are little sites everywhere of doing that.
Excellent. Blair?
I would jump in. The thing that comes to, I think there are probably a lot of examples. The thing that pops into my head right away, and I did write it in the chat too, but is just what we're doing to respond to the maternal health crisis in the United States, and thinking about workforce, particularly doulas, peers, community health workers, the intersection of maternal health and the maternal mortality crisis with the need for better access to just healthcare generally, but also behavioral healthcare, and how, and specifically then there are many elements of the Convergence framework that support and kind of build up that work. That would be what comes to mind for me.
That's super helpful. And then Stuart, can you quickly touch, because I know we are running out of time, but I would love for you to weigh in on that. You're muted.
I would just say that I think that when you look at particularly services that affect older adults, that really connecting with younger people and with different populations outside the nursing home, for example, is really very, very important. And I think it's sort of a subset, if you like, of what we were doing in this project. And I would just draw your attention to a previous project actually that Karen and I worked on, which was looking at older adults. And there was a lot of the same themes that came in there, such as, looking at nursing homes as hubs in the community, connected with all sorts of other institutions, rather than being kind of walled off fortresses, which so many of them are these days. So I just draw your attention to that. I'll put it in the chat.
Stuart, thank you. And because of the time, I wanted to thank our panelists. You are amazing. The work that you're doing and the work of everyone on this call. If you look, I've had the honor of being able to see who everybody's organization is and what you're doing. You're all doing incredibly important work. If I didn't get to your questions, I would love to talk with you about them. So please feel free to reach out. They're going to put a slide up for us that gives us our contact information. But thank you for doing the work you're doing. Thank you for pressing forward and not being content with what we are able to do today, because we will do more tomorrow together. So thank you for doing this. Stuart, do you have anything you'd like to say? Any last thoughts to sum up?
Yeah, I'd just like to say that, we see this as a sort of a pivotal stage in this project. We've got the agreement. We've been excited by that. And now we are looking for, how to get these ideas, sort of, and these proposals really command the attention of people who can make changes, either at the federal, state, local level. So we'd very much like all of you to think hard about how best to do that, and to let us know who needs to read this, what particular recommendations really, you think, strike a chord with particular needs in communities, that we need to let people know about this and know that there's a very broad coalition, really, of organizations across the sector that will help support in this way. So thank you so much for those of you who were part of this, and those of you who have joined us today to listen to this really important work.
Thank you. Hope we get a chance to work with you going forward. Thank you again to our very generous supporters, and for everybody who joined us today. We look forward to hearing your thoughts. Please do weigh in and come back in contact with us. Enjoy the rest of your day. Thank you.